Welcome to the online classes. Today's topic is chronic obstructive pulmonary disease or COPD. It is also known as COED. Myself Dr. Umesh Kumar Sapra from PG Department of RNVV, CBPAX, New Delhi. As you can see in the picture, COPD, chronic obstructive pulmonary disease, or COAD, chronic obstructive airway disease. You can see there is difference between the healthy as well as COPD patients. In the muscles there is inflammation is there in the bronchioles, thick and smooth muscles is there, and also it leads to narrowing of the lumen. Now coming to the definition, as the name suggests, chronic obstructive pulmonary disease means this is a usually progressive persistent airflow limitation which is associated with an enhanced chronic respiratory response in the airways and to the lungs to noxious particles or gases. Means, so this is a condition in which there is chronic obstruction from the level of trachea to the alveoli, and it is leading to airflow limitation in the body. As the name suggests, it includes chronic bronchitis and emphysema. New textbooks also shows that COPD also include bronchial asthma, which has been already covered, bronchiectasis and bronchiolitis. So here we only discuss chronic bronchitis and emphysema. Now coming to the chronic bronchitis. Chronic bronchitis means inflammation. So here is a chronic inflammation in the bronchioles. So definition is cough with expectoration on most of the days for at least 3 months in a year for 2 consecutive or successive years. Emphysema, abnormal and permanent enlargement of the air spaces distal to the terminal bronchioles that is accompanied by the destruction of their spaces walls without obvious fibrosis. Now coming to the pathology. In the airways there will be always a chronic inflammation, increased number of blood cells, mucous gland hyperplasia. Hyperplasia means increase in the number of the cells, fibrosis, narrowing and reduction in the number of small airways, airway collapse due to loss of tethering caused by the alveolar wall destruction in the emphysema. So these are the changes which are found in the patients of COPD. As the name suggests, chronic inflammation will be there, COPD. So hyperplasia will be there, fibrosis, narrowing as well as collapse in the later stages. In the picture you can see there is narrowing of the lumen as well as thickened mucous smooth muscles. Now coming to the risk factors. Risk factors include cigarette smoking, occupational dust and chemicals, environmental tobacco smoke, indoor and outdoor air pollutions, and some other just like genetic factor, infection and socioeconomic status. Aging population is also prone to COPD. Now coming to the symptomatology. Symptomatology includes chronic and progressive dyspnea, cough and sputum production that may be variable from day to day. Dyspnea is there which is progressive, persistent and worse with exercise. Chronic cough, intermittent and unproductive. Chronic sputum production, cough up sputum. Other features include wheezing, chest tightness, weight loss as well as respiratory infections. Physical sign in the chest you can find out barrel shaped chest, accessory respiratory muscle participation. You can see that from the patients in inspection. Prolonged expiration during quiet breathing, expiration through pursed lips, paradoxical retraction of lower interspaces during inspiration, hover sign and tripod position. Now in the picture you can see normal chest and barrel shape. Anterior, posterior as well as transfer diameter is changed in the barrel shaped chest. Now coming to the tripod position. In the picture you can see patient adopt position that leave dyspnea, such as leaning forward with arms outstretched and weight supported on the palms or elbows. Clinical manifestation: in palpation, there will be decreased vocal fremitus. In percussion, hyperresonant sounds will be there, depressed diaphragm will be there, and diminution of the areas of absolute cardiac dullness. On auscultation, you will find prolonged expiration, reduced breath sounds, presence of wheezing during quiet breathing. Crackles may be heard if there is superadded infection. In some patients, you will find out the clinical features of blue blotters in chronic bronchitis and pink puffers in the emphysema patients. That is also differentiating feature between both of the cases of COPDs. Now coming to the diagnosis. Diagnosis is related with the symptoms, exposure to risk factors, and then followed by investigation just like spirometry, as shown in the slide. Diagnosis: presence of post bronchodilator FE1 by FVC. If it is less than 0.70, it confirms the presence of persistent airflow limitation, and thus it can be diagnosed as a case of COPD. Now coming to the classification of severity of airflow limitation in COPD. In patient with FE1 oblique FVC, if it is less than 0.70. Now coming to the grading. Grade 1, it is mild. FE1 is more than 80% predicted. Gold 2, that is moderate. FE1 less than more than 50 but less than 80. Severe, more than 30 and less than 50 predicted. Very severe, FE1 is less than 30% predicted. So this is the related with the diagnosis of severity of airflow limitation in chronic obstructive pulmonary disease. Now coming to the chest X-ray or investigations. In chronic bronchitis, generally there is no apparent abnormality, but you can see increased lung markings in some cases due to smoking and other factors. In emphysema, there will be marked overinflation noted with flattened and low diaphragm, intercostal space become widened, a horizontal pattern of ribs, long thin heart shadow, decreased marking of lung peripheral vessel can be seen. This can be seen in, and sometime in COPD patient you will find out there is teardrop heart. Heart size, it becomes just like a shape of teardrop. It can be a diagnostic feature of COPD. So thank you very much. So it was today's topic. We have discussed CAS, and accordingly we have discussed COPD, chronic obstructive pulmonary disease, or COAD in chronic cases. So if you have any query, please let me know. I will try to resolve it. Take home message is COPD is always associated, or most of the time associated, with smoking. So there is changes in the trypsin and antitrypsin pathway that can also lead to inflammation. So that should also, and also you should also remember teardrop heart in the X-ray. That is also diagnostic of COPD. Thank you.